is an otolaryngologist. Laryngologist?
Otolaryngologist.
Laryngologist.
Good.
Okay,
Close enough.
almost. See, I don't even know how to pronounce some of these terms, and I'm a nurse. So he completed medical school at St. Louis University School of Medicine and residency at Loyola Straight. I worked there also. So he is affiliated with Advocate Christ Medical Center and Advocate Good Sam Hospital. And he is currently having appointments at Oak Lawn,
We have Oak Lawn office right down the street there.
Orland Park,
Orland Park as well.
and Lamont.
And we see patients in Lamont. Yes.
Okay, all right, so he's well in a great amount of the area here. So I will let you start, and then you want to get rolling.
Thank you, Susan. So welcome, everyone. It's nice to see everyone. Beautiful late summer day. So as Susan said, I'm Dr. Amine, but I'm not the Dr. Amine. Anyone here from Oak Lawn? Okay. Anyone born at Christ Hospital? Okay. Anybody familiar? Anybody work at Christ Hospital?
Has worked. Has worked.
Had work? Where?
Spiritual care department.
Spiritual care, okay. Did you
I
say
was in
you
the Gildas Club at Christ Hospital.
were- the Gildas Club? So the Dr. Amine is actually my father, Dr. Amine. So he was a neurosurgeon there for 41 years. And I like to say I follow in his footsteps. He practiced neurosurgery and he treated many people in this community. And I do get quite a few patients, definitely see people in the community who ask me about it. So just a shout out to him. He retired 4 years ago. He's doing well. I was born actually at Christ Hospital. And so this is the first library that I ever knew. So this is my library, Oak Lawn Library. I grew up coming to this library. And I came back to this library even when I was studying for medical school. So this is near and dear to my heart. Anyhow, I've been around. I went to St. Louis for medical school and I went to Loyola for residency and I ended up doing a fellowship in New York. As I was introduced, I do practice comprehensive otolaryngology, short or long for ENT, ear, nose, and throat. And I do, though, carry an interest now in the last couple of years in sleep surgery. So that's kind of going to be the topic today. Anybody here have sleep apnea? Or at least know somebody who has sleep apnea? All right, so that's why you guys are here. We'll cover some of the basics and kind of what I can offer and look to kind of understand what it is and how you treat it. So to understand sleep apnea, we're going to talk about obstructive sleep apnea. The word obstructive defines this type of sleep apnea because there's essential sleep apnea. We're not going to cover that. Majority of people have obstructive sleep apnea. And when you go to sleep, what happens? Your muscles relax, right? So if you look at this picture here, what do you see? You see the airway right here, okay? And you see the tongue, and you see the palate, and you see air trying to move past it. Well, when you relax, the tongue is a muscle, it loses tone, and it obstructs the airway. So if you understand that, you'll kind of understand why people have sleep apnea, and then how to treat it. Because if you know why it happens, you try to focus your efforts on how to treat it. The way it's measured in the clinic is by a sleep study. And when you do a sleep study, it's measuring your effort and the oxygen level, and then calculates how bad your sleep apnea is. And so this is an example of somebody who obstructs and their oxygen dips, wakes up because the body's programmed to wake up when your oxygen goes down, and then it happens over and over and over. Sleep apnea is a worldwide problem with an estimated 1 billion people who have it, undiagnosed, many of them undiagnosed. The prevalence is more common in men than women. And obviously it has to do with our weight. Now, if we go back to this picture, we'll see this is not a great picture to understand this problem, but whenever there's crowding in the area of the back of the tongue, whenever you gain weight, you gain it everywhere. You don't gain it in one place. So that includes the back of the throat and the tongue area. So that area becomes crowded, easier to collapse. Okay, so it definitely has to do, you can understand why obesity causes it's related, closely related. Now, patients who have sleep apnea oftentimes come, sometimes they don't know it, but a lot of times they come with symptoms, okay? Symptoms such as snoring or fatigue, daytime sleepiness. And if you're sleepy, you're at risk of an accident, putting your workers at risk or people on the road at risk. You're obviously snoring, like we said, is a symptom. So you can have marital issues, bed partner issues. But those are symptoms, but then we also have to talk about the medical consequences, right? If you're tired, it's one thing, but if you're at risk for medical issues, that some of them or a lot of them are actually life-threatening, right? Stroke and heart attack, diabetes, hypertension. These are all medical consequences of untreated sleep apnea. And just please also, if you have any questions, raise your hand. I'm happy to stop and clarify. So to treat sleep apnea, there are really, I would say, 4 or 5 ways. First line treatment for sleep apnea, if you're going to go see a sleep doctor, they're going to talk to you about really 2 things, C-PAP and weight loss, right? These are kind of the first 2 things they're going to talk to you about. C-PAP stands for continuous positive airway pressure. What it's doing is it's pushing air through that narrow airway and opening, stents it open, tries to force the air down. So you can imagine that's not necessarily the most comfortable thing. Probably preaching to the choir here. But if it works, it has a lot of evidence that it's effective, right? This is the most well-studied treatment for sleep apnea. And it's been around since 1980. So in 1980, it was groundbreaking. But the problem is there are about 30% of patients that end up using it, somewhere in the 30 to 50%. So anyone use C-PAP in here? You guys look like the left or the right here? Take a look at those 2 pictures. You don't look like the one on the right?
Oh.
Or you look like the one on the left? You happy and smiling?
Oh, no, it doesn't work.
And this just shows that a lot of people are frustrated with it. Like I said, if it works, it's great. People love it, they feel better if they can get it to work. But a lot of people can't really get used to it. Alternative treatments, we're going to go over a couple of these. So oral appliances are devices designed and made to pull the jaw forward. When you pull the jaw forward, it also pulls the tongue forward with it, hence opening up the airway. You can understand somebody created this device knowing what the problem was and coming up with a solution for it. In the medical field, when we're putting a patient to sleep in anesthesia, actually that's what they end up doing is when they give them some sedation and the patient, they start to obstruct. What are the first thing they do is actually pull the jaw forward because it pulls the tongue forward, opens up the airway. So that's a device that can work for some patients, but it does have some issues with it. It's non-surgical. It does cost money. It can cause long-term issues with bites, but some people do great with it. So again, it's a non-surgical option. We talked about weight loss and positional therapy. Some people are purely positional, meaning if they sleep on their back, their tongue relaxes and falls back. But if they sleep on their side or their belly, their tongue falls forward, opens up that airway. So that's also an option for some patients. Now, again, this is a nice picture showing the problem at its best, right? You have your tongue, it's a muscle, you sleep on your back, gravity pulls it down when you're relaxed, blocks off the airway, and so what do? When you look from a surgical standpoint, there have been many surgeries tried to address this problem. Anyone ever hear about this surgery? Uvuloparental palatoplasty? Or one in the back there, another one here. So this was a surgery, you look in somebody's mouth and you see big tonsils and you think, oh, those must be the problem. Well, the results have actually been very poor for this type of surgery because we really didn't understand the problem. The problem, again, is not the tonsils. The tonsils are above the tongue. They're not the things that are collapsing. Now, in some cases, they are, right? You can identify that in some cases. But the reason why you have less than 50% success rate is because it's usually not the problem. The patients who do well with this are the skinnier patients with huge tonsils. And so that's why kids would take out their tonsils, because they do have sleep apnea. Smaller airways, relatively larger tonsils, you take them out and their sleep apnea actually improves. It's also a very painful type of surgery. So we got somebody nodding. So from experience.
Yeah, I had, it was 95. I mean, it helped me a lot. It didn't solve the problem, but it helped me a great deal.
Yeah.
But they went in and they took a laser to the back of my mouth.
Yeah.
And then about 2 weeks later, I was probably 100%.
Yeah.
And then 7 weeks later, I went in for another one. And then I repeated that. So 3 times I went back.
Did they call that a layup?
I don't know what they.
Multiple laser treatments?
They just called it laser surgery.
Yeah, it's a lay, yeah, there's an act. So that's similar. It does the same thing. It stiffens the palate.
And they trimmed out a new uvula for me. It was
Yeah.
the first one they cut out.
So these types of surgeries I reserve for patients who, like we said, have skinnier, more symptomatic with snoring. I think these are good in patients who have a bad snoring problem. Now, nasal surgery is advertised. You may hear it on the radio to do nasal surgery for sleep apnea. But if you think about it, how many people stop breathing because of their nose? Well, if you ask people who have problems breathing through their nose, they usually end up breathing through their mouth, right? So they end up with a dry mouth, but not sleep apnea because of their nose. So treating the nose itself doesn't treat sleep apnea per se. What it can do is help you wear your CPAP easier, because the CPAP obviously a lot of pressure and helps the airflow. But what I want to talk to you a lot about here really is what I'm excited about, what I've been doing for the last couple of years, has been groundbreaking, is upper airway stimulation surgery. Now, since C-PAP came out in 1980, really there hasn't been anything earth-shattering until upper airway stimulation or hypoglossal nerve stimulation has come out. Now, this is not new. It started in 1993, believe it or not, where the research started in cats, but it has been approved it's been approved since 2014. And in 2019, was it 19 or 20, when insurance companies saw the data and started to approve and pay for this device. New therapy, very expensive. Insurance companies don't want to pay for it. So they wait as long as they can until they are forced to pay for it, because the data is just overwhelming. So this is not something that I learned in residency, but it's something I quickly learned to do because it's something that the anatomy is something I'm familiar with. So I learned to do it after in practice, and I've been doing it for the last several years now and have never looked back. Now, if you understand, we said that the tongue is the object that falls back. If you can find a way to push it out, just like with the jaw thrust or the oral appliance, well, somebody came up with the idea, well, why don't we use the nerve to give it a little stimulation and just have it move out of the way? Well, obviously that ended up being successful and it came up with this solution. So the device manufacturer is called Inspire, commonly referred to as Inspire. And it's about the size of, you know, a $50, a little bit bigger. It looks like a pacemaker. So when we tell patients it's like a pacemaker device, it's very much similar to a pacemaker. It's implanted. You have nothing that you're wearing except you're not wearing a mask. There's no hoses. It's working inside your body without you even being aware of it. In fact, I've had patients come back. One patient last week came back and told me that he went to work without turning it off. He didn't even know he had it working still until he couldn't talk because it was still working. His tongue kept moving and he couldn't control it. He had to go back home, use his remote, turn it off, and go back to work. So a little video that kind of demonstrates how this works. After it's implanted, you got your remote. Be sure to grab one when you're way out there on some of the tables. The actual implant goes into the chest. There's a wire that goes up to the neck and controls that tongue. When it senses the breaths, it sends a signal to the tongue and the tongue moves forward. Opens up that airway where the green circle is. You're breathing normally. You're not struggling at that point. This is pictures of people's tongues, believe it or not. These are considered, this is the base of the tongue, the point, the arrow where we were pointing at. Okay, this is before, no stimulation. Same patient after stimulation. So if you want to look and see how they look, compare it. Actually, let's go back. So if you notice, this is the airway, a little dot here. You don't see much of an airway there, do you? If you stimulate, you'll see how that tongue moves forward and this whole airway opens up. Every breath, that tongue shoots out, opens up that airway. Whereas in the other one, you can't breathe, you're just so tight. On a sleep study, this is what it looks like. Before you're activated or when the device is off, your oxygen levels up and down. And then once it's turned on, your oxygen levels stay good, right? Same thing with airflow. Obstructed, and then breathing, right? So this is just demonstrates what an actual sleep study would look like with the device when it's off and on. Now, I told you this has been FDA approved 2014, and the insurance has started to cover it because the data has been overwhelming. It's been published in the best journals, in the medical journals, including the Medical Journal of Medicine, and the data has it's been followed up for 5 years. Now, it's one thing if you show they've improved, somebody has improved some therapy initially, but is that therapy, treatment sustained for years after that? Well, there's been data that's followed for 5 years to show that. AHI, which is the apnea hypopnea index, is the number of times you stop breathing per hour. And in this study, where they used 126 patients, the average number of times people stopped breathing was 30 almost. And over the first 5 years, that went down to 9, 6, and 6. So it stayed the same. It shows that it has long-term efficacy. The Epworth Sleep Scale is actually a measure of people's symptoms, right? You ask them, how sleepy are you? How tired are you? How likely are you to fall asleep, et cetera, et cetera. And the higher the number, the more symptoms you have. So above 10 is considered abnormal, and less than 10 is normal. So the average patient in this study was 11, and over the 5 years, it stayed improved at 6. Snoring, although this isn't the reason you do it, it's measured in these studies, and there's been an overwhelming number of patients who improve, who report improvement in snoring. But you can't do this therapy, you can't do this implant because of snoring. But it does obviously help a lot of people and their bed partners. Now, if you ask, now that's data that's recorded, right? The actual AHI, which is a sleep study, that's how many times you stop breathing. But sometimes it doesn't necessarily translate over into how somebody feels or would they recommend it, right? You know, if you had a really hard surgery, you may consider like, man, was that surgery worth it? It made me feel better now, but it was a tough surgery. Well, the studies actually show that overall, if you ask all the patients, would you recommend this? 94% of patients would say, yes, they would recommend it. If you think about that, any surgery, back surgery or knee surgery or any of those surgeries, you know, how many times do you have 94% of patients would say, yes, I would recommend it? But I think that's very telling. As I mentioned, this has been published in some of the best medical journals, including the New England Journal of Medicine. There have been over 100 articles written on this, and this is old data. There have been long-term follow-up, and they've actually now several months ago now, they announced they've implanted over 25,000 of these devices worldwide. Insurances cover it, Medicare covers it, VA covers it.
Does it need to be changed?
So the battery life is 11 years. So after 11 years, yes, it does need to be changed, just like a pacemaker would. That kind of procedure is a simple outpatient procedure.
Does it interfere with any procedures? If you were to have an MRI or a CT?
So it is compatible with an MRI. You can get an MRI with it. Yes,
If you already have a C-PAP and insurance is paying for that, will they pay for that?
we'll get to that. Good question. So that's what we're talking about right now. So in order to qualify for this, you need to meet 4 things, okay? Now, the best surgeon can do this on everybody and will get miserable or won't get good results unless they pick the patients correctly, right? Surgery, you always want to pick the patients so that they're, you know, this patient's going to do well, okay? You pick the patient, the wrong patient, you may not get the best result, okay? So there's 4 criteria. 1, you have to have tried C-PAP and failed, right? Second criteria is you have to have an AHI of above 15, which means that puts you in the moderate category at minimum. So if you're mild sleep apnea, you won't qualify for this. The third criteria is BMI. BMI stands for body mass index. It's a measurement of your weight relative to your height. If you want to know what your BMI is, you can go online, click BMI calculator, and you can figure this out quickly. Medicare has a cutoff of 35. Commercial insurances, their cutoff is 32. So there is a chance that this may change. Actually, the company submitted for approval for a higher limit in the BMI, because the last thing is actually the most important thing. It's the non-concentric collapse. Now, that's something that I would see on an examination while the patient is under anesthesia. So that's the last step before you qualify, is we take a patient to the operating suite, give them some sedation, and examine their airway to understand how it's collapsing. Now, if it collapses in a concentric pattern, patient would not be a good candidate. If it collapses in a non-concentric pattern, patient's a good candidate. And if you look back at the data, that's the most prognostic thing. That's the most important thing. So that's why the company is actually submitted for an alternative criteria, but that's to be seen if we'll go through.
Did you say all 4 have to be met?
Yes,
Not 3 out of 4.
all 4. Yes,
Silly
sir.
question. Concentric connection means what exactly?
Concentric means it's like a circle. It comes down and closes like a sphincter. Non-concentric means linear. So that's something I can't tell you what you are by just looking at you or looking in your mouth. I have to put you to sleep and look with a camera at your throat while you're sleeping. It's done under twilight, just like a colonoscopy. Yes.
What percentage of patients are ineligible when you actually get there to check that?
About 80% qualify once they get there.
Okay.
Yes.
How long is the surgery for?
The surgery, how long it takes? You're talking about the implant?
Yeah.
Takes an hour. Outpatient surgery.
So at what point, like, in other words, what do you do in order? You start out with a sleep apnea test, or
Right here.
what's the point of doing everything if you have the non?
Yes. So the first thing you do is you have to be diagnosed with sleep apnea, right? You go to your sleep doctor, your primary doctor, they set you up with C-PAP. That's first line. Then if you're,
What about the sleep test?
the sleep test, are you talking about the home sleep test?
The overnight one.
Yeah, so that's That's what you need to do to be diagnosed with sleep apnea.
Yeah. Does it have to be recent?
So Medicare 2 years, commercial insurances can be, there, it's variable. But we tend to just say 2 years. So you can do a home sleep test, I'm not sure if that was what you're referring to, or a sleep study, which is in a lab.
Yeah, I thought you could just pull the records from the previous
So-
study.
So you have to have a sleep study to be diagnosed with sleep apnea. So then your doctor, your primary doctor, your sleep doctor says, you have sleep apnea, here's a prescription, you need a C-PAP, your C-PAP gets delivered for you. You try it out, you're uncomfortable, you can't do it, whatever, you return it, then the patients come see you.
Now, what happens if you had a sleep study years ago? You did the C-PAP and it just didn't work.
Yeah,
And
many
then
patients.
you've never
come
done
to me
anything
like that.
again. Do you have-
Many patients come to me like that. What I do is, if it's many years ago, I tell them, let's just get a new sleep study, okay? And we can do home sleep tests now. And then we look at that AHI, okay? The fact that you've tried CPAP, we're done, we're not doing it again, right? Then we're just gonna update your sleep study. We're gonna look at your BMI. If we have those three things now, then we go to the airway exam. That makes sense? Yes.
I'm just curious, what is the difference between a home study and one in the lab?
So
Is
the,
it-
the,
Are they
the sleep,
diagnostically different?
yeah, so the sleep studies done in a lab are just very comprehensive, okay? Now, for the home sleep tests, they're historically been, they underestimate the sleep apnea, but now they're getting better and better. They're never gonna be the same as an in-lab sleep study as comprehensive. Did you see that? This is a lot of data that's collected in an in-lab study.
But
Home sleep
home
tests,
one is acceptable?
they are acceptable because we're looking for a few things. We're looking at the number of times you have obstructive sleep apnea,
Mhm.
okay? And whether you have a central component or not, okay? So that's all we need to know.
So your primary would order the sleep study.
Your primary or your sleep doctor, right? But if somebody, like you said, you've tried it and you've returned it and you're not gonna try it again, those patients come to see me, right? They're welcome to come see me. And I would say, well, let's get a new sleep study since it's been 10 years. So I'll order that. It'll come to your house. You'll wear it for one night. I'll get the report. And then we go from there.
So actually, he had it years ago, Joe, and he really had bad sleep apnea. He
Mhm.
tried the CPAP for a long time.
Yes,
Didn't work, and he hasn't done anything since.
yes,
So he could come directly to you.
yes. That's the most common type of patient that ends up coming and see me. I get plenty of referrals from the sleep doctors who have a huge patient population and have had returned their devices, but they still have sleep apnea. Well, what are they gonna do? You know, they don't have any other options really.
Right.
And so you get a lot of those patients, but there's a lot of now awareness about this. You've probably seen it on TV even, or on your phone with advertisements. And so patients do come directly to me. Events like this, right? You know, just creating awareness. There's somebody, there was a hand over here, I thought.
I'll raise it now though.
Yeah, go ahead, sir.
Same thing the woman said about her husband. I have the CPAP machine. I tried it. I can hardly breathe at all with that thing on the mask over your nose, over your mouth. So I'll be eligible to at least see you at that point. I have a watchman in my chest. that prevent them getting it.
Is that a pacemaker or defibrillator or?
It's that.
Yeah, so none of those are contraindications for the device. Those are usually implanted on the left side. The device is implanted on the right side. So,
So other than having the battery after 11 years, are there any other problems?
so once we go through the screening, okay, and we do the airway exam, we implant. After the implant, you wait about a month, and then it turns, you give it time to heal, basically. You go get it activated, because it's not like you get it implanted and you go home, you turn it on.
Oh.
So it's about a month, and usually that's done by one of our partners or sleep partners who turns it on for you. They give you your remote, you go home, you turn it on, and you start using it. Now, this is a little different than CPAP in that CPAP, if anyone's tried CPAP, you go through what's called either titration study or an auto PAP. So they actually measure how much pressure you need that day to see what's ideal. Well, with Inspire, what they do is they give you your remote and they give you 10 settings. And they say, start at the bottom and work your way up. So every week you go up a notch. You go up a notch every week until eventually the stimulation is strong enough that you'll feel it when you wake up. And then you back down. And that's kind of where you sit. Okay, so that process takes about 4 to 6 months. Okay, because you can keep going up. There's not just 10 levels. They can reset it for you to go higher and higher and higher, because everyone's different. And then once you get to sort of a cruise speed, you do what's called a fine-tuning sleep study. That kind of finalizes it, optimizes it, fine-tunes it, and then you go into what's called long-term management. You just see once every year or something like that. Yes.
So from what I'm kind of understanding, from beginning to see you to when this actually works, I mean, it can be a year.
No,
I mean, you're saying
No.
you gotta go up 10 notches and go
No.
up,
no, it doesn't take that long. So when somebody sees me,
um,
I'll do the airway exam within a couple weeks, usually 2-3 weeks. You gotta get it approved through insurance and implanted. That takes about a month. Activation another month, so that's about 2 months. And then that's when you start using it, right?
but
So it
when you
takes-
start, it doesn't work, you're saying.
Well, yeah, so you start at the lowest level, so it takes 1 week at a time, you go up. So the average is about 4 to 6 months. From the day they see me to the time where they're feeling great.
But as it's going up, it's probably still working.
Yeah,
but
of
just
course,
not
it's
at
not
its optimal.
100%, right?
Right.
So the average is about 4 to 6 months.
Excuse me, I have a
Yes, sir.
question. So with that, if you already doing the CPAP and you're gonna do your transformation from the CPAP to the Inspire, are you still wearing the CPAP mask or do you terminate the CPAP
Well,
mask altogether
So this
to
is
begin this process?
good question. So when somebody comes and sees me, nothing is 100%, right? This isn't 100% going to be successful. So the first question I'll ask the patient is, are you using CPAP? If they say yes, I have to understand their motivation, why they're looking to get something else, right? Some patients are like, I can't sleep in the same room as my wife, right? Or I travel and I get stopped, and one time somebody told me they took their CPAP and so at check-in, it was like some country, somebody thought it was a bomb. And it was a funny, real story. Anyhow, so I have to understand the motivation again.
She's uncomfortable as well as
Right.
for travel.
So if somebody comes and tells me, I've tried CPAP, I can't use it, then I'm like, that's when I start going down this path of this may be for you. But until it's activated, yeah, you try to use CPAP if you can.
Well, I speak for her. she mentioned about the CPAP being uncomfortable with the purified water and how, what the.
Yeah, so it's all part of the comfort and tolerance of a patient, and that's all subjective. And the insurance companies don't question it. If the patient comes and tells me, I can't tolerate it, it's uncomfortable, I'm claustrophobic, well, that's what the patient told me, and that's what I'm writing down, right?
So there doesn't have to be a 1 month or 2 month trial.
There is no limit, no.
So precisely where in the body is this insert?
So the device is inserted into the right chest, right here.
So looking at the photo and he's
Right.
upper chest.
It's right here. It's maybe 3 to 4 inches below the clavicle. Right, in the middle of the chest.
How is it?
And how does that wire, how do you do the wire? I'm curious on that wire going to the top.
You gotta come and see me in the operating room.
You can't, oh, man.
So there are 2 incisions. One is here and one is here. And you have a tunneler that goes from.
You have a
here.
what?
There's a device, it's called the tunneler.
Oh,
So the device, the wire is tunneled underneath the skin up here.
and it attaches to your tongue? or-
No, it
No.
attaches to the nerve that controls the tongue.
Okay.
Okay.
I was just curious.
Yeah.
They don't have Wi-Fi yet.
Not yet.
Is there anything that could cause that to fail?
David, do you know, the failing of the
The
device?
device.
I mean, it's a electrical device.
Have you seen problems with it, or
What kind of?
have you had problems with it not working?
Well, so it's not 100% of patients who do great. So the success is somewhere between 70 to 90%. Remember, we said 90% of patients say they would recommend it. So those 10, 20% of patients, you end up working with them to see if you can get them at least some improvement, right? In extreme situations, if the patient, you can always just leave the device and not work, use it, and go back to C-PAP if that was something you want to consider again. In the extreme situation, you can always remove the device, but that's another surgical procedure. Now, that's far and few in between. I've never had to do it. Yes, sir.
I came in late. What causes you to have a CPAP machine?
So it goes back to the problem, which is obstruction in the airway. So when you sleep, everything relaxes, the tongue relaxes, and it falls back and it blocks the airway.
Oh, okay.
Oh,
Yeah.
Yes.
Are there other contraindications besides not qualifying for the four ways that you mentioned? Talking about conditions you might have
No absolute contraindications.
that are easy to
But
see. People who
If
have
somebody's
this.
on oxygen or, it's just how, age is not a contraindication. Actually, some of my happiest patients are in their 80s. There's actually some patients who can't turn it on themselves because of dementia.
Oh, okay.
And their caretaker turns it on for them, right? There's studies that show now that kids, right, with Down syndrome, now kids they'll never put a mask on, right? So Down syndrome kids are high risk for sleep apnea. So it's been researched, so to see why don't we do these in these kids so that their mom or dad can turn it on for them, treat them. So there are definitely advantages. There's a lot of ways this can go, but very few contraindications other than just a poor surgical candidate, like very unhealthy.
How would it work if it's not metal, so it won't?
So it's non-ferrous, meaning it's not magnetic.
Oh, okay, so that's what makes it okay to go have an MRI.
Right.
So how does, for instance, having an EKG work? It doesn't interfere because it's not.
It won't have any.
As long as it's not turned on, it's not,
Right,
it's an app.
exactly. Yeah.
Okay,
And it's a closed system, so it's not emitting electric signals outside of the wires.
How big is the device and put in your body?
It's about $50, maybe bigger, a little bit.
But actually, the chest is open to put it in.
So you make an incision and put it in, you make a pocket, yes. Were you gonna ask a question?
Well, actually, I have two questions.
Yes.
I have a right, a torn rotator cuff.
Yeah.
That's gonna cause a problem for.
No, it's far away from that.
Okay.
I got a question.
I'm sorry, one second. She had two questions.
Yeah. So what about, people who have like, night terrors and those type of, sleep problems?
So if you have other issues, and this is part of the, this is part of the diagnostic workup. When somebody is seen, you have to identify, is this patient, do they have, I saw a patient lady today with sleep apnea, but she had terrible fibromyalgia. She can't sleep not because necessarily she has sleep apnea, but she can't sleep because she's in pain all the time. So if I put this device in her and help her sleep apnea, her sleep may not improve. I have to talk to the patients about that. You can't expect me, I told her, you can't expect this to fix everything. Yes, sir.
Yeah,
So that, you have to look at everything, right? That was the point of that.
Would that be, something that you would, consider not doing?
Well, you have to make sure you clarify with the patient, right? If they have insomnia, for instance, right? This isn't gonna treat the insomnia, right? There are people who have restless leg syndrome. It doesn't treat that. Yes, sir.
yeah, I got a pacemaker.
Yes.
Would that affect it?
No.
No.
Will not affect it.
So you use that thing to turn it on, and then you don't sleep with it on you, right? You put it on your,
That's correct.
it's just to turn it on and then put it away somewhere.
Yes.
Okay, so you can.
And it has a timer. If you don't turn it off, it'll turn off after 8 hours. And those are all customizable. If it takes you longer to sleep, it won't turn on until you can customize that. You can change it to 45 minutes, an hour, right? Some people take long. If you get up at night, you want to use the bathroom, there's a pause. You can hit pause and go to the bathroom, come back, and it'll turn back on. It's like a snooze. Yes.
So I had a home study, exam done, and I also had the one on the left done. Would I still be able to, like, make an appointment to, like, see you?
Yes, anybody who wants to come see me, I would ask them to do two things. If you can get your sleep study, that's helps so much,
Okay.
okay? The other thing I would say is so patients aren't coming just, if you want to come and learn about it, it's fine, but what I don't want is somebody coming and saying, well, why did I come? I can't get this. So one of the number one cause you can't get it is for BMI. If you want to know if you're a candidate, make sure your BMI is within the range. Go to the BMI, go to Google, type in BMI calculator, height and weight, and it'll tell you. And what you're looking for is under 35 in Medicare, under 32 if you have Blue Cross Blue Shield or commercial insurance.
So Medicare is pretty rigid with 35.
They're less rigid, actually.
So if his was 36,
So, oh, yeah, cut off, done. You can't get it.
okay.
You have to lose weight. Yeah. Cutoffs are hard cutoffs by all the insurance.
Okay.
What did you say Medicare is?
Medicare is less than 35. And then the commercial insurances are 32. Great question.
I would just have one more question.
Yes, sir.
Once this is in service, for your sleep pattern, is it to be used consistently, or say for instance, someone that considers themselves taking the power nap and don't turn it on and find themselves in slept throughout the night, does it automatically come on?
If you don't
when
turn it
they
on, it's not gonna
register?
turn on by itself. If you don't use it, you're not gonna get the benefit of it.
So, okay. In an instance that someone, like again, takes what they consider power nap,
Yeah.
go to sleep and they find themselves with the shortness of breath or not breathing at all. So it doesn't automatically,
No. Now, maybe in the future, it'll sense when you sleep.
I'm trying
That's
to
down the
gather-
line. I've heard that, right?
Yeah, I'm trying to gather between turning on the machine. and
Yeah,
Going
exactly.
to the formality.
Yeah,
putting
there's
mask
a
on,
whole ritual you go
what
through with
this,
CPAP,
this,
so.
that's-
But with this, yeah, you do have to turn it on, you have to be cognizant, you have to turn it on, and then go to lay down, and it'll turn on after you go to, well, the timer starts, say, 30 minutes, 45 minutes after you go to sleep, whatever it is programmed to.
So, I'm sorry.
No, go ahead.
I didn't mean that. So if your body is one who's emotional.
It won't have any impact.
It will have no effect
No.
to the sleep pattern.
Correct.
Okay.
Yes,
This, what was AHI, what does that mean again?
apnea hypopnea index, and it's a measure of your severity of sleep apnea.
What's the second word? High what?
Hypopnea,
Hypopnea.
yeah.
Thanks.
That's the number you get after you have the sleep study
Correct.
from your doctor.
Yes.
So you don't have to figure out what that is.
Right.
The doctor will tell you.
I know, okay.
Oh,
I just,
okay.
yeah,
Just thought that might
Yeah.
help.
I just wanted to know what it was.
Yeah.
Thank you.
Yes.
You mentioned if you get up to the bathroom, you can pause it.
Yeah.
What happens if you don't pause it? You just go to the bathroom?
A lot of people do that. They just, again, the feeling of the movement of the tongue is like blinking. You don't notice it until you pay attention to it.
I see.
So
But it's harmless if you just
it's
do that.
harmless, yeah. Don't try drinking while you're going to the bathroom,
Oh, okay, yeah.
Don't try talking.
because your tongue is gonna be moving. Yeah.
And you want that to look
So
at
it's
my
on-
primary,
this is on-
try to make
it's
an
on.
appointment with you?
It just depends on your insurance. If it's an HMO, usually you need a referral. If it's other than that, usually you don't. So I would ask your primary, and you're welcome to take one of
The
the,
office number from there?
yeah, and it's up here too. If anyone wants to take a picture of that, it's up there as well. It's in the folder.
Okay.
Yes, sir.
If we had a CPAP machine, we don't like it, it's very uncomfortable.
Yeah.
That throw through, has to be before we see you, they're just gonna say, this sucks, I don't wanna use it.
I'm sorry, one more time?
If we don't like it, we can't breathe well
Yeah.
through it. We just come to see you, we have to go through this other stuff first.
Well, you can come see me, and if the CPAP, if you don't like it, right, you don't have to tell anybody else about it. When the insurance companies need documentation that the patient can't, or is not tolerating CPAP. All that means is the doctor wrote it in his note, and the patient told them that. That's it. There's no proof of it in a test or anything like that.
So to get that way, to see the doctor first,
To
before
get,
they see you.
say
Even
that,
though we can't tolerate the CPAP machine,
yeah.
get that before we come to see you.
Yes, if you want, anybody who's interested in this, in Inspire, has to have tried CPAP. So somebody, you or anybody else who has sleep apnea, hasn't tried CPAP, because whatever, they heard about it, they're like, no way, I'm not gonna even try it. They won't qualify for this.
I think he's asking, can he come to you without going back to his doctor to have the doctor write the note that he can't tolerate?
No, I would write that.
Yeah, he can go right. to
I
him.
would write that, yes.
But your BMI also has to be.
Your BMI is, like I said, it's one of the most, it's the thing that disqualifies the most patients.
That affects your old budget, it's disqualified.
I'm sorry?
That's your old budget, it's maybe disqualified.
Yes.
No.
Old budget,
Old has nothing to do with it.
if you're budgeting enough, you might disqualify.
Only those 4 things we talked about.
Why is that, doctor?
Because the studies, when they looked at people, right, they may have taken 20 patients, different weights, different BMIs, and they looked, implanted, say, 20 people. These worked, these didn't, so they cut it off.
And so it was more apt not to work in people who were
Exactly.
heavy.
And anytime I implant these patients, and they're on the border, I always tell them, I say, look, you're on the border, you start gaining weight, this thing's not gonna work for you.
But life might improve so much with it. that you
That's the
might end
hope.
up
That's the
improving
hope.
Your lifestyle, losing weight anyway.
Exactly, that's the hope.
Wouldn't that be nice?
You said it doesn't help with restless leg,
Right.
what does?
You have to talk to sleep doctor about that one.
Relief factor. Relief factor, cure my restless leg syndrome.
Is that an over the counter or?
No, mail order. Google, DuckDuckGo relief factor, it's great stuff.
So, I'm sorry. So if you have other sleep disorders that can be taken care of, will this still be something that you can do anyway?
Yeah, so if you have disorders, right? You have multiple things causing you poor sleep. So it's a part of the puzzle, it'll treat only that part of the puzzle, the obstruction part,
Okay,
that's it.
that's fine.
So, what we just discussed today, this is what we have been seeing, what myself have been seeing on commercials. Directly inspired, because I see the commercial, but don't really pay attention to the commercial because I'm not in need of, but I recognize the commercial that I'm sitting there, but the device.
Yeah.
You all have been
Yeah.
advertising on television with the commercials.
Yeah.
And this is a commercial, you know what I'm saying? that-
Yeah, it's that same
It
commercial,
is
right?
that same commercial. Okay.
Well, it's 7:20. If anyone has questions, I'm happy to stick around and answer them.
So now it's-
Thank you for coming.
Thank you. Thank you for being here.